Hi. So, hello everyone. Good evening everyone. The first thing I'll say is कि वैसे क्यों देख रहे हो यार मेरे को there is India versus Pakistan that will start in a moment. मतलब मुझे खुद लग रहा था why am I taking this session today? You know, everyone will be excited about the India versus Pakistan. But having said that, so we'll have our previous year question discussion today of the past 3 years pediatrics question. So hopefully you are able to hear me. If everyone is able to hear me, gives a thumbs up, gives a, you can hear me if the people who are watching this live right now. I'll try to finish it as soon as possible so that we both together, we all can together actually, we can actually go to watch the India-Pakistan live rather than learning about pediatrics, frankly. And I genuinely believe that, frankly, studies and everything aside, there are few moments, these are the few moments that we live for, right? These are the few things that we do end up living for. Padhai to hoti rehti hai. There should be a small healthy dose of fun and activity, and definitely irrespective of whatever stage of preparation that you are in, I would advise everyone that maybe 1.5 hour today, you should definitely, watch the India-Pakistan match. Use that as recharge, use that as, sort of, ki chalo, haan, break hogi. And then from tomorrow, and hopefully, I'm pretty sure we'll win. It's World Cup. India will win. And with that energy, with that motivation, start from tomorrow or start from night itself for your NEET PG. That is going to happen the next week. All right. So, everyone. टॉस तो यार सब लोग जीतते रहते हैं, उसमें क्या फ़र्क पड़ता है, टॉस पाकिस्तान जीते क्या होगा, मैच तो इंडिया को ही जीतना है, होपफुली मैच इंडिया ही जीतेगी. ऑलराइट, सो शैल आई स्टार्ट? थैंक यू, थैंक्स अ लॉट. I'll begin the discussion. I'll start with the discussion. Alright. I'll start with the discussion of the recalls. Alright, so I'll begin with the discussions of the recalls. Let's start. So the first question that I'm going to discuss is this. All right. So the first question is that a 10-year-old child, let's see the question very carefully. The question will have the answer. Okay, let's see the question very carefully, and question will have the answer. So one of my seniors always used to tell me there is not a correct answer, there is not one correct answer, there are 3 incorrect answers. So even if you have ruled out 3 options, you will get to the correct option, and always apply that thinking even if you don't know the correct answer to that question. Alright, think logically towards all the options themselves will tell you which is the correct answer. The best part about an MCQ exam is that unlike a subjective exam, an objective exam, an MCQ based exam, the answer is in front of you. You just have to find it. Alright, now let's see. A 10-year-old child weighing 30 kg, he is presenting to you with history of loose stools. All right. So when you examine, there is how much dehydration? There is severe dehydration. All right. Now lab investigations are as follows. So what are the lab investigation? What is the initial management as per the ISPAD guidelines? ISPAD is International Society for Pediatric and Adolescent Diabetes. All right. So the question itself is telling you the patient is probably having diabetes. Even if, let's say, the ISPAD guidelines, the word ISPAD was not mentioned in the question, the investigations will tell you actually. Let's assume that this ISPAD was not there in the question also. Let's assume that. Let's make the question a little bit tougher. What is the initial management according to the recent guidelines? Then let's see what investigations has the examiner given us. So examiner is telling us that the RBS is 550. The RBS is what? 550 milligram per deciliter. He's telling that the pH is 7.01. So there is acidosis. It's a child, it's a 10-year-old child. Acidosis, dehydration, history of loose stools. And the glucose, urine glucose is also high. They might have given urine ketone also, that might be 3+. Basically, the entire history is pointing towards that this child has DKA. He has diabetic ketoacidosis. The history is pointing towards that. The blood glucose levels, the pH, the urine glucose having a lot of glucose, all this is pointing towards that the child right now has diabetic ketoacidosis. As far as the definition of diabetic ketoacidosis is concerned, if I actually go to the definition of diabetic ketoacidosis, there are 3 components of diabetic ketoacidosis. First, that the blood glucose level, the RBS, the blood glucose level should be more than 200 mg per deciliter. It should be more than 200 mg per deciliter. There should be acidosis, as the name itself is telling you. Diabetes, how will we know that there is diabetes? So, for diagnosing DKA, you should have RBS of more than 200 mg per deciliter. the pH, because there has to be acidosis, the pH should be less than 7.3, and there should be ketonuria also. There should be presence of ketones also. So ketonemia should be there. Ketonemia should be there, which can either be in the form of that the urine dipstick has ketonuria 2+ or more, or your the blood ketone levels are more than 3 millimole per liter. Now, you don't need to remember the exact definition. That actually hasn't been asked, to be very honest. But the clinical scenario, definitely, the child having an RBS of 550, having acidosis, having urine glucose positive, having severe dehydration, everything is pointing towards that this child has what? This child has diabetic ketoacidosis. Now, as far as the management of diabetic ketoacidosis is concerned, let's see the options first. Manage ABC, manage ABC, manage ABC, manage ABC. Okay, so the examiner knows, you know this answer, so he's not going to do it. Then either we give 20 ml per kg or 10 ml per kg. This is the first point of differentiation. The second point of differentiation is, when do we start insulin in the management of diabetic ketoacidosis? You start insulin after 1 hour, or you start it immediately along with when you start the NS bolus. So two options, two radically different options. One option is saying you start insulin after 1 hour. This option is also saying start insulin after 1 hour. Then there are two options which are saying that you are going to start along with giving the bolus. Okay. So the first point as far as diabetic ketoacidosis management is concerned, that you have to remember that first there is fluid resuscitation. Followed by insulin. Fluid resuscitation for the first 1 hour. In the first 1 hour, you are not going to start insulin. You will start insulin only after the first hour has gone into fluid resuscitation. Remember, in diabetic ketoacidosis, yes, the glucose is very high. That is the problem. You have to get the glucose down. You have to reverse the acidosis, but it is a case of dehydration at the core. The body is dehydrated. So the first thing that will kill the child, high glucose won't kill, the dehydration will kill the child. So first, and the fluid not being there, the shock being there, that will kill the child. The first hour, the guidelines clearly mention you have to go for fluid resuscitation. The guidelines clearly mention that you have to go for fluid resuscitation, followed by, the first hour is always fluid resuscitation, followed by starting insulin. So immediately you can see these two options, B and option C, are ruled out. Option B and option C are ruled out because you do not start insulin simultaneously. You start insulin after 1 hour. Now comes option A, or option B. Now there is severe dehydration. If there is mild or moderate dehydration, then the initial bolus is of 10 ml per kg. If there is severe dehydration, the initial bolus is of 20 ml per kg. And hence the correct answer is option A. Manage ABC, NS 20 ml per kg and start insulin after 1 hour. First 1 hour fluid resuscitation, then you start insulin. How much insulin? This one, 0.1 international unit per kg per hour. That dose is given correct, but they have given incorrectly the timing. You do not start, you start only after 1 hour. Alright. And on top of that, the initial fluid resuscitation, whether it has to be 10 ml per kg or 20 ml per kg, will be dependent upon the type of dehydration. In mild or moderate dehydration, you give 10 ml per kg. 5 to 10 ml per kg, and in severe dehydration and shock, you give 20 ml per kg. Simple, right? Understood? Hence the option is going to be option A. All right. Now let's move on towards the next question. This is a rather easy question. Child presented with gum bleeding, low hemoglobin, low platelet count. You made a diagnosis of AML, which is the likeliest mutation, and they have given you a set of 3 mutations. Now let's look at, if you look at the image carefully, you can see what is referred to as a faggot cell. You can see a faggot cell. There are multiple OR rods concentrated at one place. So it's an AML with faggot cell. We know it is going to be M3, that is acute promyelocytic leukemia. In acute promyelocytic leukemia, what is the mutation? We all know the answer. Please tell me the answer. Yes, absolutely. It's translocation 1517. Translocation 1517, which is your PML rara, which is your PML rara. Alright, easy question, don't mark it incorrectly. You can clearly see OR rods and you can clearly see multiple OR rods. In fact, this is an abnormal promyelocyte. This is an abnormal promyelocyte. This is an abnormal promyelocyte. Alright, you see faggot cells, you see abnormal promyelocyte. The answer is clear as a day, clear as night. It's translocation 1517. Alright, now let's move on towards the next question. Let's move on towards the next question. Which of the following is the best sign to indicate? Which of the following is the best sign to indicate adequate growth in an infant with birth weight of 2.8 kg? Read the options and tell me the answer. Let's see if you know the answers. Can you tell me what would be the answer? Can you tell me what should be the appropriate answer to this particular question? This is not an as easy as a question as it looks like. Slightly tricky, but still definitely a very easy answer. Not that tough. I would consider it mild to moderate in nature as far as yeah, so most of you are answering it correctly. Yes, most of you are answering correctly. 2 people have answered. Both of them have answered it correctly. Yes, so answer is A, an increase in length by 25 centimeter in a year, obviously. Now, let's see logically why other options are ruled out. First of all, anterior fontanelle does not close by 6 months. It closes at 12 to 18 months. It actually closes at 12 to 18 months. So this option is ruled out. As far as option B is concerned, 300 gram per month till 1 year. So 300 into 12 is equal to 3.6 kg. If we add 3.6 kg plus 2.8, this makes the baby what? This makes the baby around what? This makes the baby at baby around 6 kg. This makes the baby at around 6.4 kg. Ideally, a baby should triple the birth weight. Ideally, the baby should triple the birth weight at the end of 1 year. At 1 year, it should be 3x the birth weight. It should be 3x the birth weight. Here the weight is coming to be only 6 kg, which is approximately twice the birth weight. So option B is also ruled out. Option C is definitely ruled out. Now we all know that when the baby is born at birth, a normal baby has a length of what? 50 centimeter. This becomes 75 centimeter at 1 year, and there is a gain of how much? 25 centimeter in first year. So obviously option A is the correct answer. In the next 1 year, that is by the end of 2 years, your height is approximately 87 centimeter, 88 centimeter. Then by 4 years of age, you are 100 centimeter. By 4 years of age, you are 100 centimeter. And beyond 4 years, you gain height at 6 centimeter per year. Beyond 4 years, you gain height at 6 centimeter per year. How much per year? You gain it at 6 centimeter per year. Alright. So this is the normal length, how the normal length of a baby increases. At birth 50, at 1 year 75, then 87 at 2 years. At 4 years we become 100. If they ask you when the length doubles the birth length, the answer is going to be what? The answer is going to be 4 years. At 4 years it is 100 centimeter, at birth it is 50 centimeter. So at 4 years of age, the length is double that of the birth length. Has been asked as far as INI-CET is concerned, so you should definitely remember this small point as well. So here the answer is going to be increase in length by 25 centimeter 1 year. Why is option D not correct? If you look closely at option D, looks okay. It's not like it doesn't look okay. Option A is a better option, so you have to choose a better answer. But if you look closely, it says weight under 75th percentile and height under 25th percentile. Now, it makes sense. Technically, the child might be fine also. But if you go for a weight for length chart, you might actually realize that the child might actually be obese or overweight. Because weight is near 75th percentile, length is so less, it might actually be possible that the child might be overweight or obese. So this is not a correct option. This is a less incorrect option. A is definitely correct. So we go with A, option A, the best possible answer, A. Alright. Now let's come to the one. A newborn presents with chest retraction, dyspnea and lethargy. You made a diagnosis of respiratory distress syndrome. Deficiency of which of the following has caused this? Another very important, easy question. Respiratory distress syndrome is caused due to a deficiency of what? It's caused due to a deficiency of surfactant. And surfactant, the main phospholipid in surfactant is, tell me which is the main phospholipid in surfactant. So people have answered it already correctly. It is lecithin. It is what? It is your lecithin. So they haven't given surfactant in the option, but they're giving you the main component of surfactant. And the answer here is going to be option A, That is your lecithin. Lecithin is the correct answer. In fact, we use LS ratio, lecithin to sphingomyelin ratio, to denote what is the maturity of that particular baby. And if it is LS ratio is more than 2, we consider that the pulmonary maturity has been achieved, and the baby can actually, likely that the baby won't really have respiratory distress syndrome. Why? Because higher lecithin means higher pulmonary surfactant. Higher pulmonary surfactant obviously means lesser respiratory distress syndrome. This child has respiratory distress syndrome, so obviously which deficiency has been causing? Lecithin deficiency is the one which will be causing this particular disorder. Alright, so this is as far as this option, question 4 is concerned. Moving on towards the next question, question number 5. Alright, now you have a 3-month-old baby. He is presenting to you with jaundice and clay-colored stools. Clay-colored stools basically immediately means what? It immediately means you have to think of conjugated hyperbilirubinemia. Not unconjugated, conjugated hyperbilirubinemia. Lab investigations show that the baby has conjugated hyperbilirubinemia. So, examiner himself has told you there is conjugated hyperbilirubinemia. Then the liver biopsy shows periductal proliferation. What is the likely diagnosis? Tell me what is the likely diagnosis. The likely, you have absolutely written it correctly. Everyone has done it correctly. It is biliary atresia. In biliary atresia, you have characteristically conjugated hyperbilirubinemia, and on liver biopsy, you see ductal proliferation because there is biliary atresia. All right, that's where the ducts in the liver tend to proliferate. There is periductal proliferation. All right, so there is periductal proliferation characteristically, which is seen only in biliary atresia. Now, Crigler-Najjar, let's rule out options. Like I said, you should always rule out option also. Crigler-Najjar is unconjugated hyperbilirubinemia because of the deficiency of which enzyme? UDP-GT. UDP glucuronyl transferase enzyme is deficient. Now, Crigler-Najjar syndrome is of 2 types. It's of type 1 and type 2. Type 1 has complete absence, while type 2 has around 10% of the activity, around 10% activity, 5 to 10% activity. In type 2, you can consider giving what? You can consider giving phenobarbital. While in type 1, even phenobarbital won't be effective because no activity is there. There is absolutely zero activity. So phenobar will act where, right? So as far as type 2 is concerned, consider giving phenobarbital. Now, Dubin-Johnson and Rotor syndrome both can cause conjugated hyperbilirubinemia, but they do not have periductal proliferation. All right, they can have deposits. They can have the liver can have some pigment deposits as far as Dubin-Johnson syndrome is concerned, but they do not typically tend to have periductal proliferation. Periductal proliferation is very, very characteristic of biliary atresia. Now, moving on. Now, this is a very interesting question. Tell me the answer to this question. Then I will tell you the how do we get to the correct answer. Basically, the question is talking about a torch infection, first and foremost. Born with prematurity, low birth weight, decreased hearing, patent ductus arteriosus, and bilateral cataract. So they are giving you the characteristic triad of a congenital infection. That is bilateral cataract, PDA, and hearing loss. They're giving you the characteristic triad. They're already giving you the characteristic triad. Bilateral cataract, PDA, and hearing loss. This triad is seen where? This triad, absolutely correct. This triad is seen in congenital rubella syndrome. So we know the answer. But let's also look at other options, what will be seen in other torch infections also. As far as CMV is concerned, if they want to make you answer CMV, they will very characteristically give you, if they want to give you CMV, they will very characteristically give you periventricular. They will give you periventricular calcifications. If you see periventricular calcification in the question, think CMV. As far as toxo is concerned, as far as toxoplasma is concerned, toxoplasma has its own characteristic triad. Toxoplasma has its own characteristic triad. What is the characteristic triad as far as toxoplasma is concerned? Tell what is the characteristic triad as far as toxoplasma is concerned? There is chorioretinitis, there is hydrocephalus, and there is diffuse intracranial calcification. intracranial calcification. This triad will be seen as far as toxoplasma is concerned. This triad will be seen as far as toxoplasma is concerned. All right. This typical triad will be seen in toxoplasma. If they are giving you PDA, bilateral cataract, hearing loss, the answer is congenital rubella syndrome. Whenever there is PDA in question, always think rubella. If you see PDA in question, always try to think of rubella. They love asking questions on congenital rubella syndrome and it causing patent ductus arteriosus. Not once, not twice, multiple times. So always remember patent ductus arteriosus, congenital rubella syndrome. Never forget that. Even if you forget bilateral cataract and hearing loss, don't forget that PDA is congenital rubella syndrome. PDA is congenital rubella syndrome. Alright. Alright. Now, let's move on towards so these were the questions last year that were asked. Now let's move on towards 2022 questions. Now as far as 2022 questions are concerned, now this is an interesting question. I've actually made a modification to this question in the next slide. Let's read the question. You have a 2-year-old child who presents with sudden onset breathing difficulty. He has sudden onset breathing difficulty while playing. Small clues. While playing, he had sudden onset breathing difficulty. There is no prior history of any breathing disorder. Okay. Chest X-ray shows hyperinflation of the right lung and left lung is completely normal. Which of the following statement is true regarding this particular case? All right. So this is where some confusion is coming. तो पहली चीज मैं बता देता हूं. So those who are answering D, this is a case of foreign body obstruction in airway. This is a case of foreign body in airway. I'm pretty sure this you have gotten. यहाँ तक तो तुम पहुंच गए हो, तभी तुम B या D में confuse हो रहे हो, right? Because when did the respiratory distress start? It started suddenly while playing. So he probably was playing with some coins, he probably was playing with some, Lego-like pieces that he took inside and that caused the respiratory distress. Sure. So there is foreign body obstruction. Foreign body obstruction, the treatment of choice, always remember, not flexible bronchoscopy, it is rigid bronchoscopy. So option D is incorrect. Now why does hyperinflation result? Hyperinflation results, let's assume this is a bronchus. And there is a foreign body here. Now this foreign body, if it is not completely obstructing, there is incomplete obstruction. Air will be able to go inside, but it won't be able to come outside. So air is able to go inside, it won't be able to come outside. This is what is referred to as the ball-valve mechanism. But this ball-valve mechanism will result in hyperinflation, yes. But this is seen in incomplete obstruction, not in complete obstruction. The option here is saying incomplete obstruction. Incomplete obstruction, what will happen? There will be complete obstruction, no air will go. And that segment might actually collapse also. In incomplete obstruction, the ball-valve mechanism asks. So this is incorrect. Ball-valve mechanism leads to such condition in incomplete obstruction, not in complete obstruction. Alright. And obviously, if there is a foreign body there and it has completely obstructed the bronchus, what will happen? In that particular area, there will be decreased air entry. That will help you confirm the diagnosis. So here the correct option is option B. Correct option is option B. Alright. Now let's move on towards the modified version of this question. So I've modified this question. So examiner is fully possible. They can change the question a little bit. Now, A option is ruled out, B, D option is ruled out. It's exactly the same question, but I've modified the option slightly. Here, the correct answer is going to be what? Here, the correct answer is option C. Because I've changed option B. I've made it diffuse area of decrease. Focal area of decrease confirms the diagnosis of foreign body. In a specific area, if there is foreign body obstruction, that area won't have air entry. not a diffuse area of decreased air entry. And an incomplete obstruction, as I talked about in this particular, in the last slide, incomplete obstruction, you will have ball wall mechanism, incomplete obstruction. So here option C is going to be the correct option. So this is how it's fully possible. See, again I'll tell you, previous year questions, 80%, 70 to 80% of your paper is going to be something which the examiner has definitely asked in the past 7 to 10 years. It's not possible that they have not asked. But obviously they are not fools, right? They will slightly twist the question. And in your excitement, you'll be like, exactly same question hai, option halke se change ho jayenge. Some options might be different. And they'll, you will mark the incorrect option in your excitement. Always read the question carefully, always read all the options carefully, even if you feel you have already done this question, even if you feel this is an exact replica of a previous year question also, even then read the question, all the options carefully, then get to the correct answer. You have 1 minute, approximately 1 minute, 45 to 1 minute for every question. Spend that time and then get to a logically correct answer. No option, no answer will go wrong. Alright, now let's move on towards the next question. A 4-month-old infant who is born to HIV positive mother now presents to you with diarrhea. Okay, what is the next step of investigations? Now, the first thing that you have to understand that during the first 6 months, this is something which we learn every time, that during the first 6 months, the babies have maternal antibodies. The babies have maternal antibody. So the mother is HIV positive. Even if the baby is not infected by HIV, he will still have HIV 1,2 antibodies. Why? Because the mother would have transferred those antibodies. But they do not represent the fact that the baby has infection. So in an infant, especially in a child who is less than 6 months of age, you cannot do, they're giving you 4 months, you cannot do HIV antibodies to get to the diagnosis of HIV. So HIV antibodies is not the correct. Alright, rule out giardiasis. Yeah, think about this way. There can be multiple causes. Giardiasis in fact is known to cause chronic diarrhea more as compared to acute diarrhea. Here they haven't given any picture. It might as well assume it to be acute diarrhea rather than chronic diarrhea. This is not the correct option. Start ART. We haven't even confirmed the diagnosis and we'll start ART. No, not that. Alright, not that. So obviously in the first 6 months, the way to confirm is doing a PCR, because then you will actually check whether the viral RNA is there or not. That's why HIV PCR is an investigation of choice, especially in infants, especially in children less than 6 months of age, if the mother had HIV, because the mother will transfer the maternal antibody across the placenta. Alright, hence the option here is going to be HIV PCR. Hence the option here is going to be HIV PCR. Understood? Why? Because in the first 6 months, maternal antibodies are going to be there, so you can't do antibody tests. Let's say I want to get tested for HIV, you want to get tested for HIV. In fact, whenever in your internship, if you're getting tested for HIV, what do? We go for HIV antibodies. Why? Because we are not infants. But in an infancy, especially during the first 6 months, antibodies can be a problem because they can be transferred from the mother. In that particular scenario, it's the PCR which is preferred, not the antibodies. Alright? Now, next question. This is a relatively easy question. Child has come to you with multiple episodes of loose stool. He's drowsy, lethargy. Skin pinch is going back very slowly. He's not accepting breastfeed. What is the grade of dehydration? Tell me what is the grade of dehydration. What is the grade of dehydration? So this is relatively simple. So as far as grading of dehydration is concerned, we use consciousness, the consciousness status of the baby, skin pinch, these are the 4 things that are given in IMNCI. We can also use the status of tongue. We can also use other criteria for dehydration, but these are the 4 which are given in IMNCI. So, no dehydration, some dehydration, and severe dehydration. No, some, severe. No, some, severe. As far as no dehydration is concerned, the child is what? Normal, active, playful. In some, the child is irritable. In some, the child is irritable. In some, the child is irritable. In severe dehydration, the child, because so much loss of water from the body has happened, the child is now comatose or lethargic or drowsy. So, drowsy. As far as skin pinch is concerned, normal time, In some it goes slowly, in severe it goes back very slowly. It goes back very slowly. Alright, as far as thirst is concerned, there is normal thirst. In some, because body has lost water, he's going to drink eagerly. Eager thirst. Drinks eagerly, eager drinking. In severe dehydration, again, because the body has lost so much water, the baby is essentially drowsy, lethargic, he won't be able to drink. Can't drink. He won't be able to drink. Alright, as far as eyes are concerned, again normal, sunken and very sunken. Sunken and very sunken. If any two signs of severe dehydration are there, we will call it as severe dehydration. Here it is saying very slowly, this is covered. Here it is showing drowsy, it's covered. Not accepting breastfeed essentially means not able to drink also. So they have given you three signs of severe dehydration. The answer is option A, severe dehydration. Alright. Now let's discuss the 2021 question. In 2022 just 3 questions came. In 2021 slightly more questions came, 7 to 8 questions came. So let's begin our discussion of 2021 questions. As far as 2021 questions are concerned, the first question, read the question, a rather lengthy question but a easy answer, because the question itself is telling you what the answer is. You don't need to look too much what the options are, you just need to look at the question, read the question carefully and you will get to the answer. So Anirudh has asked a very interesting question. Actually the exam is easy. Let me tell you. मैंने तो जो दिया था मुझे तो आसान ही लगा था. But generally speaking, if you are prepared well, the exam is, if you are prepared okayish well, I'm not even saying that you are a topper or anything. If you are prepared okayish well, the exam will seem easy. Exam is easy. What happens is that if you have not revised in the last 7-10 days, which I keep on talking about, you'll get confused between the options. So remember the congenital rubella syndrome question. Let's assume it was not that direct. Let's make it slightly twisted. Let's say there was only patent ductus arteriosus. Or let's say there was no patent ductus arteriosus, there was calcification. Now calcification will make you reach, it is going to be CMV or toxo. But then you will forget whether it is toxo or CMV. You will forget periventricle calcification is characteristic of CMV. You will forget that diffuse calcification is characteristic of toxo. Alright. Now these are the small things that you need to revise at least 10 days, 15 days before the exam, so that the question will stay easy. You are the one who's going to make a mistake. You're absolutely right. The paper is not tough. Give the paper, you will realize the paper is not tough. Even if you take INI CT also, which people say is very tough, in INI CT, 70% of the questions are not tough. Only 30% questions are tough. Majority of the paper is not tough. Majority of the paper still is easy. The problem is not the paper being easy. The problem is you messing up. The problem is you on that exam day, because your MCQ practice is not thorough, you will get confused between the options. Sometimes we tend to overthink. Very common. Even I did. I'm pretty sure you all also must do. That you know the answer, you will overthink it and get to the wrong answer. Don't overthink. Be cool, be calm. Revise last 7 to 10 days, whatever you can of the high yield topics. Give the exam. It will go like a breeze. Alright, so everybody has given it absolutely correctly that this is SSP. This is characteristically a case of SSP. I don't need to tell you what SSP is. Here, what is characteristically they are saying that there was fever with rash when the child was 1 year of age. Basically, this was what? This was measles. This was measles. And now the child is having what? Now the child is having later in the adolescent age group, now the child is having myoclonic jerk. Measles, myoclonic jerk later, you have your diagnosis, SSP. How do you get to the diagnosis? You get to do the anti-measles IgG antibodies in the CSF. Option B is the correct answer. Option B is the correct answer. So most of you have answered it correctly. The question will be easy. Right now, the simple fact is you guys are not stressed. The simple fact is that we teachers, we are, obviously we are friends, we are your friends, we are your mentors. So in that relaxed environment, these questions seem easy. In that tense environment, the same question will seem tough. And that is the trick on how you get from a 10,000 rank to 1,000 to a 100 rank. Those who are able to keep their cool, those who are ekdam bindas will get the top 100 rank, top 1,000 rank that they desire. जो वहाँ पे सिली मिस्टेक्स करेंगे उनकी रैंक उतनी उतनी पीछे होती रहेगी. I've always said this and I'll always tell you, topper is not decided by getting a difficult question correct. Topper is decided by who did not get a single easy question wrong. Everyone will make silly mistakes. The top doesn't make silly mistakes. It's not that he will get the difficult question right. He will ensure that कोई silly mistake ना हो. सारे easy questions, 100% strike rate उन silly easy questions में. Okay. Now let's move on towards the next question. A child has come to you with generalized edema. Serum cholesterol is 248. Urine protein is 3+. Urine microscopy is telling you that there are fat droplet. The likely diagnosis is, tell me the likely diagnosis. Tell me the likely diagnosis. Tell the likely diagnosis. Now this is an example where you will get confused. See, normally option, obviously the answer here is, let me tell you the answer, option is C, you guys are correcting correct. But I'll tell you exam mein kya hone wala hai. What will happen in an exam? Exam mein you will be like, yaar Goodpasture syndrome mein bhi kya fat droplets hote hain? Examiner itna easy question dega. Examiner can't give such an easy question. And then you will change the option from nephrotic syndrome to Goodpasture syndrome. This is what will happen in an exam. Okay, here it is as easy as a day. There you will overthink. Hey, the urine protein is not given 4+, it is given 3+. When you know that nephrotic range proteinuria is 3+, 4+. There you will be like, cholesterol ka cutoff kitna tha? Was it 200 or was it 250? So 248, less than the cutoff. It might be Goodpasture. This is how you will overthink, and such an easy question will become tough on the exam day. Alright. So let me tell you what is the diagnostic criteria for nephrotic syndrome. Important thing, because this is a 2021 question, that's why I'm telling you. Nowadays, nephrotic syndrome does not have hyperlipidemia in its definition. Very important thing to remember. No longer nephrotic syndrome has hyperlipidemia in its definition. Yes, hyperlipidemia still is going to exist in nephrotic syndrome, but for definition of nephrotic syndrome, it does not have. What is the definition of nephrotic syndrome? Nephrotic syndrome has a triad of, you need to have three things. You need to have nephrotic range, you need to have nephrotic range proteinuria, you need to have nephrotic range proteinuria. What is nephrotic range proteinuria? Nephrotic range proteinuria is when the urine protein is more than 40 mg per meter square per hour. More than 40 mg per meter square per hour. 40 mg per meter square per hour, 24 hours, multiply by 24, more than 2 gram per meter square in a day. More than 2 gram per meter square in a day. If you're doing a urine spot, if you're doing a spot sampling, then urine protein to urine creatinine ratio should be more than 2. Urine protein to urine creatinine ratio should be more than 2. If you're doing a urine dipstick, then 3+, 4+. 3+, 4+ is nephrotic range proteinuria. So this is the definition of nephrotic range proteinuria. So to define nephrotic syndrome, you should have nephrotic range proteinuria plus hypoalbuminemia. Albumin level should be low. How much low? Less than 3 gram per deciliter, and you should have generalized edema. If these three things are met, then you can call the patient as having nephrotic syndrome. No longer is hyperlipidemia, cholesterol level more than 200 in the part of the definition. Having said that, although it's not a part of definition, it does not mean it doesn't occur. Nephrotic syndrome patients still will have hyperlipidemia. They will still have hyperlipidemia. Alright. So why does venous thromboembolism occur in nephrotic syndrome? Makes sense, right? So venous thromboembolism occurs because you don't only lose albumin in the urine, you also end up losing protein C and protein S. These are antithrombotic proteins. When you lose these antithrombotic proteins, thrombosis chance increases, and as a result, you end up having venous thromboembolism. Other minor factors which contribute to venous thromboembolism is the fact that these patients will also end up losing some amount of immunoglobulins. Their immunity is going to be low, higher chance of infection, and we know that infection can also precipitate thromboembolic phenomena. This is the reason why nephrotic syndrome patients end up having thromboembolism. The reason for hyperlipidemia is also the same. Since there is protein loss, there is lack of lipoprotein which can bring the peripheral circulating lipids back into the liver. As a result, these lipoproteins stay into the circulation, causing an increase in the lipid levels of the body. Okay. So yes, Sheetal has given it absolutely correctly. There is loss of protein C and S in the urine, and that results in increase in thromboembolic phenomena in nephrotic syndrome. Let's see the next question. Again, a very easy question. Child has come to you with upper limb hypertension, lower limbs not palpable, pulses not palpable, and chest X-ray showing you notching of ribs. Examiner is like, le lo yaar, le lo, ek answer le lo, question le lo, tell me the answer. Tell me the answer. Tell me what is the answer. So this is a very easy question. I mean, we need to explain it. Is coarctation of aorta. Aorta is coarctated. It is compressed. Lower limbs don't receive blood flow. Lower limb pulses not there. Lower limb doesn't receive blood flow. RAS activated. Upper limb hypertension. And on top of that, because of the intercostal arteries getting a lot of blood, there's notching of the ribs as well. So this is a very easy question. Coarctation of aorta. I won't go too much into details. If they wanted to give you patent ductus arteriosus, if they wanted to give you atrial septal defects, especially atrial septal defect, they would have given you fixed S2, fixed split S2. If they wanted to give you, they would have given you fixed split second heart sound. If they wanted to give you patent ductus arteriosus, they would have given you machinery like murmur. And if they wanted to ask you about bicuspid aortic valve, they would have given you what? They would have given you Turner syndrome. Turner syndrome. Examiner has some pet things that they will give. If they are giving you fixed split S2, ASD. If they are giving you machinery like murmur, patent ductus arteriosus. If the examiner is giving you notching of ribs, coarctation of aorta. If the examiner is giving you Turner syndrome, bicuspid aortic valve. That's how you get to the answer. These buzzwords. These are what is referred to as the buzzwords. Ensure that the buzzwords are revised before the exam so you don't get them correct. You don't get them wrong. Alright, so everyone has given it correctly. Now let's move on to the next question. Child is a known case of HIV. CD4 counts of 50. Which vaccine should be avoided? This is again an easy one. Killed, live. CD4 is 50. Will you give live vaccine? No, right? So here the option is going to be option A. Option A is the correct answer. Option A is the correct answer. MMR has to be avoided. Killed vaccine still can be given. Alright. So this is an easy question. Now let's move on towards the next one. A baby presents with tachypnea. In the emergency, he has carpopedal spasm. Causes. Interesting question. Tell me the answer. He has carpopedal spasm. Tell me the answer. So always remember, that's why we have asked this question. Hyperventilation results in respiratory alkalosis. Respiratory alkalosis causes tight binding of calcium to albumin. It causes tight binding of calcium to albumin. So there is a decrease in calcium, free calcium. There is a decrease in free calcium. This will result in carpopedal spasm. So the correct option here is alkalosis. The correct option here is alkalosis. Understood? Hyperventilation, you are removing all the CO2 from the body. If you have removed all the CO2 from the body, what's going to happen? Respiratory alkalosis. Whenever there is respiratory alkalosis, the calcium ions in the body, they get attached to albumin. There is higher propensity to get attached to albumin. and this results in decrease in the freely available calcium. Freely available calcium goes down, carpopedal spasm results. All right. Now let's move on towards the next question, that is question 6. Another very easy question, for example, not that tough a question. Child had a ventricular shunt for hydrocephalus. Now this shunt was replaced because of shunt malfunction. After replacement, there was irritability and loss of appetite for 3 days. Rectal temperature shows that there is basically what? There is fever. There is what? Fever. So post shunt replacement, now you are having fever. Post shunt replacement, now you are having fever. Now obviously if you want to investigate for the cause of this fever, in any case of fever, you are obviously going to suspect infection. In case of any infection, 2 possibilities are there. One possibility here is that there is shunt infection. If there is shunt infection because you have recently replaced the shunt and there was shunt malfunction also, you need to do tap from the shunt. And on top of that, obviously it's possible that there is just a general systemic infection also. You need to do blood culture also. So the correct option here is going to be option B, blood culture, and you do a CSF from the shunt tap. You won't do isolated lumbar puncture and CSF. You will do CSF from the shunt. You will do the shunt tap because you want the CSF from the shunt to see whether that is showing signs of meningitis, when that has a lot of neutrophils, a lot of proteins, right? You won't do a simple lumbar puncture. You will do a blood culture and CSF shunt from the shunt tap. Both the things will be there. And you will send the CSF for culture sensitivity, although it's not given here. But both the things need to be done. So option B is the correct answer. Option B is the correct answer. Option B is the correct answer. Now let's move on towards the last question in our discussion. This is last question. After this, we are done for the discussion. So it was not a big discussion. It was a 1-hour discussion. What is the answer to this question? And now we'll watch the India-Pakistan match. Let's hope India wins. Again, an easy question. You can very clearly see, forget about whatever the history is there. Can you see a figure of 8? Can you see a figure of 8? Or what is referred to as the snowman? And we know the snowman heart is seen in total anomalous pulmonary venous connection. Total anomalous pulmonary venous connection. So all of you guys are absolutely correct. It is snowman heart which is seen in TAPVC. Remember, TAPVC is of 3 types. There is supracardiac, and then there is directly into the IVC, directly into the right atrium, that is your cardiac, and then you have your infracardiac, where the blood goes into the pulmonary veins, actually go into the inferior vena cava. In these 2 you will see figure of 8. In these 2 you will see figure of 8. You will see figure of 8, the supracardiac and the cardiac ones. As far as the infracardiac one is concerned, you will actually see a white out lung. You will see white out lung. So just a small point, remember this. Only in the supracardiac and the cardiac variant will you see figure of 8. In the infracardiac variant, in fact, you will see white out lung. Small point that you need to remember. With this, not many questions from pediatrics. Actually, a lot of questions are actually mismatched from pediatrics. They can be asked they can be probably taught in medicine also. They can probably be taught in pathology also. And hence the number of questions from pediatrics looks small. Having said that, ensure, even if you don't do systemic pediatrics, this is for people who are going to give the NEET PG exam and going to revise in the next 10 days. My general request to you is that don't focus too much on systemic pediatrics. You would have already done it in pathology and in your systemic medicine part. So you don't really need to revise systemic pediatrics per se. Revise neonatology, revise general pediatrics. In general pediatrics also, basically the developmental milestones and the anthropometry. That's about it. Vitamins are covered in biochemistry, so you don't need to revise them. Malnutrition, again, a lot of portion is covered in biochemistry. SAM, just the definitions and the complications, don't go too much in details of SAM. That is important from your prof point of view. That is not important from your NEET PG point of view. They don't tend to ask that detailed question. Kwashiorkor marasmus, I'm pretty sure you already know the difference already. So for the next 10 days, you can plan your revision in such a way that systemic pediatrics, more or less, you can leave, or it is already covered in path or medicine or other subjects also. Surgery also has a certain portion of it. Obs-gynae also has a certain portion of it. Don't need to do that. NICU, neonatology, definitely revise. Developmental milestones, a must do. Definitely revise your developmental milestones and definitely revise your anthropometry, your height, weight, length, how they progress and all that. These three things if you revise, because rest, micro, somewhere else you will probably revise, you will be able to get to an answer. But these three things are specifically core pediatrics, and from these three topics you will have 5 questions, 1 or 2 questions from each topics. And these 5 questions are going to be easy questions. Like I said, the questions are never tough. The questions are easy. You will get confused. Revise these topics, do these 5 questions, and you will sail through the exam as far as pediatrics is concerned. All right? So advice is basically for someone who's giving the exam for the first time, don't be underconfident. Mark, I would always say that mark more than 80 to 90% marking should at least be there. Out of the total questions, if there are 200 questions, mark at least 180 questions. Mark at least 180 questions. Don't go below 180. Be more aggressive in your marking. If you have ruled out one option, simple, the rule of thumb says that you have to go and attempt the question. Try to rule out options and get to the answer. Revise in the last 10 days. If you're not able to revise the entire syllabus, that's also fine. Revise first and second prof. First and second prof yaad nahi rehta. Final prof, you have already done final prof. Since you are giving it for the first time, you will have an idea. Revise first and second prof and give the exam. If you feel you cannot revise the entire syllabus, 19 subjects you cannot remember, that's okay. Revise first and second prof and give the exam. You will still come out with a decent enough rank. So the 3 topics that I said are your growth and development, and a portion of genetics. Again, genetics will probably be covered as far as your pathology is concerned. All right, so you can consider growth, development, and neonatology. How to reduce negatives? As far as negatives part is concerned, don't be in too much of, okay, I have to reduce my negatives. Think of it this way. If you're getting 1 negative, for that you should have 1 guess which is getting you correct. If that ratio is maintained, don't worry. Because 2 guesses, 1 correct, 1 incorrect, you are in positive. So don't worry, you have to make certain guesses in the exam. There is no harm in that. If all guesses are going wrong, then evaluate that whether you have revised it and then not getting it correct, or whether you have not revised it and you are just randomly making a guess. Don't do the random guessing. Go logically 4 options and try to eliminate 1 option and then get to the answer. I'm pretty sure then your negatives will reduce and your guess answers being correct will also improve. No, you cannot give NEET PG after passing final year. You can give it after internship. For those who are scoring 90 to 100 corrects, cardiology, someone asked cardiology, do we need to do pediatric cardiology? I will say, actually medicine में cover होती है. Tamim sir teaches this very well. मेरे को भी जो सारी knowledge है Tamim sir से ही है. But having said that, if you feel like doing cardiology, yes, in systemic pediatrics, the one topic that you can definitely consider is doing cardiology and a little bit of IMNCI. Some dehydration, severe dehydration, and your pneumonia, no pneumonia, pneumonia, severe pneumonia, that you can definitely consider doing, but otherwise, systemic pediatrics, more or less, you will remember. Now, as far as those are scoring in the lower range, in the 90 to 110 corrects, they are scoring. My simple advice to you is, see where you are getting the answers incorrect. What is the, and if those answers are simply because you have not revised, the 100, 110 correct will immediately improve to 130, 140 correct if you revise in the last 3-4 days high yield topics. The GTs in any platform, be it eGurukul or any other platform, they're slightly tougher. They'll definitely be 20 to 30% tougher than the exam. The actual exam is easier. So if you're able to revise the high yield topics in the 5 days, those 90 to 110 corrects will actually improve, ensuring that you don't do silly mistake, ensuring you read all the 4 options and you go logically, you don't get too panicky. Then you will get that 90 to 110 will get to 130, 140 correct zone, even on the exam day. I've seen every person getting that extra 10 or 20 correct on the exam day if they have done the revision properly in the last 6-7 days of the high yield topics, whatever they feel are the high yield topics, but they have revised them correctly. You know, what happens is a lot of people in the last 7 days who just don't know what they are doing. So they will do just probably one subject, they will revise one subject, they'll randomly keep on doing something here, something here. No, make a plan. Even if it is 50% of the syllabus, even if it is 30% of the syllabus, but make a plan. This subject I will do these topics, this subject I will do these topics, this subject I will do these topics, and these 10 subjects I'll revise before the 7 days before the exam and give the exam. 100% your corrects are going to improve. Now, Bhavika, this is a very important thing I want to tell you. Don't rely on me for high yield topics. Solve 7 to 10 year previous year papers and you'll yourself realize what are the important topics. I created my own curated list. The high yield topics can differ from person to person. Although the high yield topics are same for everyone, I understand, but it's fully possible that for you the high yield topic is very easy to remember. So you really don't need to do it in the last 5 to 7 days. But some other topic is tough to remember and you need to do it in the last 7 to 10 days. Right? So create your own curated high yield topic list from doing the past 7 to 10 year papers. And when you have done your past 7 to 10 year papers, you will easily realize, okay, these are important topics. These topics I tend to forget more. And then I will focus it more during my last 7 to 10 day revision, ensuring I don't get them wrong. Okay. All right, chalo. I think it's 1 hour. We have done all the questions. This is what I will tell everyone. Success is not final, failure is not fatal, and it's the courage to continue that counts. All right. All right, let's go and watch the match now. Thank you and have a nice day.